So it's my pleasure to introduce the next speaker, who, for those in the room, is easy to spot, as this is the lady who is the only person in the room with a uniform. So Rear Admiral Mix is a senior policy administrator within the US Department of Homeland Security and serves as advisor for the Minority Officers Liaison Council. She has substantial experience in case management and in planning and implementation around the various hurricane disasters in the US. She became the chief nurse in 2019, is an officer of the Surgeon General and the US Department of Health and Human Services for the recruitment, assignment, deployment, retention, and career development of nurse professionals. She has 25 years experience as a clinician, public health practitioner, educator, and emergency manager. One of the things that I was keen to do was to set context, first of all, for digital health. What the Rear Admiral will do is set the context for public health. And without stealing her thunder, when she and I spoke recently together, her daughter comes up with a fantastic phrase, which is, imagine a world where. The Rear Admiral, thank you.
Hello to everyone. And so I do thank you for this invitation to join in this most important conversation. And I think, what I want to leave with you all as I begin speaking are a couple of things. The first one is that I hope that every single person in the room, as well as online, hears something that's new that you can actually take in and take back and understand how to integrate it in the work that you do, no matter where you are. The second is an understanding that nurses tend to be one of the most forgotten populations within the healthcare workforce, although we are the most plentiful, and that is across the globe. So I bring you greetings on behalf of our Surgeon General of the United States, Vice Admiral Vivek Murthy. I do serve as the chief nurse, which means I stand as the nation's chief nurse. Next slide. So just quickly, I'll just kind of, you can go to the first slide. Just to give you the context of who I am and where I serve as the chief nurse within the United States Public Health Service. Next slide, please. Our public health service is comprised of nearly 6,000 officers across the globe who are charged with maintaining, monitoring, and advancing health and safety across our nation through various policy programs, et cetera. One of the key things to understand is that we all have what I call our day jobs across many of our federal agencies, but we also have the responsibility to deploy in times of national disasters, public health emergencies, et cetera. Next slide. It's also important to understand that while I serve as the chief nurse, I have 10 other colleagues across multiple disciplines. Why is that? Because none of us can do it alone. It absolutely takes all of us, and it's important to note that even as a public health force within the United States, it takes all of us. Next slide. So just to, again, place some context, while I'm here discussing kind of my perspective as it relates to the United States Department of Health and Human Services, it's important to understand that, again, we are connected globally. And what I might share might be specific in some areas within this country. I challenge you to understand where it overlaps and where it aligns with your experiences all across the globe. So understanding the mission of the Department of Health and Human Services, note that we go from our most local, right? Our states, our local areas, our tribes, our territories that come together to bring the message of the community, that come up to the federal level or the national level, which for us is the Centers for Disease Control and Prevention, that formulate our public health policies and programs, and on to connect in with each of you across the global sphere, because we, again, are all connected. What happens to one of us happens to all of us. Next slide. So as we talk today, let me start with kind of what I frame out as the evolution of public health, if you will, right? There was a time in the late 1800s where we were first discovering exactly what causes disease and illness. We're understanding the things that are happening in the community that actually cause the disease, cause the implications that people are experiencing across the world. So as we move forward, we recognize that there was a greater need for us to be a bit more organized in how we address these problems, right? So across the United States, and I'm sure across the globe, we developed these public healthcare systems in order to address these newfound things that we were noting, right? Unfortunately, that became a very siloed approach where public health was operating in one area, primary care was operating in another, and the hospital system was operating yet in another. So there were fine programs. However, they were not interconnected. They were not related very well. So as we move forward into what we call public health 3.0, right? After experiencing recessions, after experiencing many instances where our populations were devastated, we moved into this area where we recognize, eureka, I've got it. There's more to health than just being in the hospital and being sick. There are things that happen, right? Things that happen in people's communities, where we live, where we learn, where we play, where we pray. These social determinants of health actually came into being and came as part of the conversation to understand that we've got to meet people where they are, addressing their needs where they are in order to make a difference. I will say that for the nursing community, this was one of those moments where we said, well, that's of course it is. That's how we learn. That's what we've always been taught, right? And so while social determinants of health might be a new phrase for many people, I dare say that the nurses across the globe are finding that that's just how we do life, right? So again, I invite you to understand and take this journey with me as we address, where we left off with Public Health 3.0, which was pre-COVID, to where we are now and all the things that have come into play and what I want to leave you with as we move forward to understand what's waiting for us on the other side. Next slide. So again, I say, we have to get to a point where we're leveraging nurses and most especially public health nurses. It's important to note that public health nursing is a specialty in and of itself. Many people understand that if you're an intensive care nurse, right, or a maternity nurse, people understand that as a specialty. What I offer, though, is that public health nurses are actually an untapped resource across the globe. We may be called different things, but as I go through the next couple of slides and you understand our role and function, you'll understand who those people are in your own communities across the globe. So again, I'll go into a slide on the next slide in just a moment that talks about our public health nursing roles and function, how we engage with respect to those aspects of Public Health 3.0 that I've mentioned. It's also important to understand that the conversation of Public Health 3.0 brings with it this notion of a chief health strategist. And what that means, just like in any other sector, is that you have someone who's actually responsible for pulling it all together. And I offer that in many instances, we see that physicians are placed as chief health strategists. Do we know that physicians are not the only ones who can operate as chief health strategists? If you didn't know, I'm here to tell you that physicians are not the only ones who can operate as chief health strategists. And I invite you to explore that role and open up the opportunities to those who are skilled and trained and educated to do the work, regardless of what their license or credential might be. The other aspect that's important to nurses, as well as many of you, is the notion that we must center community. It's not good enough to build policies and programs that are for people without actually engaging them in the development. So we have to center the needs of the community if we actually want to have impactful and effective policies and programs that move from it. I've mentioned social determinants of health, and then as I get to my close, I'll talk a bit more about what I mean when I say upstream versus midstream versus downstream thinking. Okay, next slide. So the first conversation that I want to have, right, because, some people understand nursing. Some people, if you ask them, well, what is a nurse? Most people will explain their very personal experience with a nurse, whether it's them or a family member, and how wonderful that nurse was, right? But if you ask people, well, what is nursing as a profession? It's a little bit different. The slide has a lot of details, and you're welcome to read it as you like. But what's most important to take into consideration is that nursing as a profession exists to serve those who are most underserved and those who are most vulnerable. And what we stand to do is to really impact a person's experience in the world, right? I tend to use the example of, a provider providing a diagnosis of diabetes, if you will, right? It is the nurse's responsibility to understand that person's experience hearing the diagnosis, understanding what that diagnosis means, and actually helping them figure out how to live their best life in the context of this new awareness. So there's a small part of it that has to do with the actual clinical, hands-on, direct care experience, but even more, understanding how that person is feeling. Because as a nurse, we have responsibility for the biological, the psychological, the social, the cultural, and the spiritual, and now the political experience of that person in this thing that we called life. So as you look across the comparison, understand that, physicians tend to focus on, and rightfully so, right? Based on the skills and training on the illness and making sure that that person has as the most successful and positive outcome, right? Public health is actually looking a little bit further and understanding how do we actually create the environment within which people can thrive. So I also presented more so as a reactive phase, where that's our hospitals, that's our direct care systems. A proactive phase, which is our primary care systems, right? Screening, getting ahead of things. I offer that public health is the predictive phase. That's the phase where we actually want to understand how we can create something to prevent all that we know might happen if we don't do something. So I offer again that none of the three sectors that you see on the slide can operate independently. However, what I do say is I invite you to have nursing as a stronger voice no matter what the conversation is. Next slide. I won't go through every single area of the 8 roles and functions of public health nursing on this slide, but what's most important is for you to understand that in the center of it all is policy and advocacy. Advocacy not only for the patient, but for the family, for populations, and for communities and all groups, right? And it's also policy driven, because in public health, that's one of the fine and keen aspects of what we do across the world. I will point out, though, if you'll notice, it's only one of the 8 areas that says clinical. Again, I say most people think of nursing in the very much clinical direct care sector, but I offer that public health nurses especially are the belly button to all that you need to happen in communities across the world. Whether it is that cross-sector collaboration that we just heard about, whether it is understanding care coordination, right? I call it making sense out of nonsense, because oftentimes when patients are hearing it or clients are hearing it for the first time, it does sound like nonsense. And so the ability to have someone on your side who can actually help it make sense so that we can make sure that those who have access to least have the opportunity for the most, right? And then finally, of course, research, because it's not good enough to do it if you're not disseminating so that others can replicate it and make it as unique as it is needed for the populations that they serve themselves. Next slide. In social determinants of health, what I want to show here is an understanding, right? On the left in the sphere is a conversation of all those things that I said before, where people live, they work, they play, they pray, they learn, right? That social context aligned with their very real experience of disease or illness, right? The education system, the level of poverty, racism, all of the things that people experience every day. These are confounded on top of everything else that's going on. So if we start having conversations that are on the far end of the slide, which speak to morbidity and mortality, and that's where we stay, we lose on our understanding and our ability to focus on all of those things that are occurring on the left part of the slide that really tell the full story, right? What I offer, though, is that we have to actually move from talking about it to actually doing something about it. So as you move from the bottom to the top of the slide, what you'll see and what you'll understand is that we have an ability to make sure that our awareness actually informs the policies that are developed no matter what level you're engaging in, no matter what sector you're engaging in, because I dare say that social determinants of health are not specific to health. There are social determinants of learning. There are many social determinants, and they impact everything and everywhere. And so I offer that we not focus just on the bottom, but we actually move to the top and understand how we, especially in the room and online, can be in the right places and spaces so that we can make these conversations a reality. Next slide. So as it relates to equity-centered data and health systems, so one of the things that I'll share is that CDC actually, as our public health agency within the United States, is in a very critical position in order for us to understand how we can have a more equitable approach to sharing data, but also to collecting data. And you'll see on the next slide what I mean by that. But it is important that we make sure that our data are accessible, right? They're usable, they're relatable, and they actually tell the story of the people where we need the story to be told most. It is also important to understand that across our sectors, people have varying degrees of resources to enable it. So it's one thing to have a great idea. It's far another to actually be able to implement it for it to reach the vast population. So we have to understand what's in the way of us actually achieving this equity-centered data systems that we all speak about and will continue to speak about over the next coming days. Next slide. So two of the examples that I'll share with you that are actually in use across the United States. So one, the health equity tracker that actually comes out of the Morehouse School of Medicine in Atlanta, Georgia. So this health equity tracker, it actually allows you to drill down to a community and county level in order to understand the differences in populations, whether those differences are by race or ethnicity or by gender, right? Disability or level of ability. So you're able to drill down, you're able to see all of these different data points and data elements, whether it's by disease, whether it's by access to care, et cetera. One of the things that is important that Morehouse also speaks to is the fact that we don't have data on some of our most vulnerable populations. So it's almost like, what good is a data system that's providing you information about health equity if you actually don't have the data on all populations? And in our country, those that are missing are often those who are most underserved, right? Those are our racial and ethnic minorities, as well as those who live in the most rural areas. And so if they are not a part of the story that's being told, they're not a part of the data that are being shared, how then will we ever expect them to be the focus for our policies and programs? And so I challenge you to understand where those gaps exist in your own communities and figure out how we can ensure that all people are counted so that all people are part of the story that we share. One of the other examples that I have for you on the slide is the Social Vulnerability Index that is out of CDC. And what this index does is it helps us to understand where communities are most vulnerable so that when there are times of disasters and public health emergencies, we already know who's already had it difficult, so that we understand that what's been compounded and what we might need to do. Even better, how can we enhance and inform preparedness so that we're on the front end of those who we already know, whether it's by geographic location, whether it's access to care, whatever the situation is, that we actually know where those who are most vulnerable live and exist, so that when we are designing programs and interventions, we actually target them to those who need it the most. What I also always say is that if you design a program based on those who are most impacted, those who have the least, those who have what they need will most certainly benefit, even if it is indirectly, right? But your target must be those who are most impacted and have the least access to the services. Next slide. So again, as I talk about advancing in public health, it is a conversation that moves us from a very clinical-based conversation to one that is more population-based and community-based, right? It is not good enough to build pretty buildings, build pretty systems, and have it just sit there. It just sits as a pretty building, right? If no one comes, you've not improved access. So we have to get to a point where we are bringing services where people need it and meeting them where they are. It's also a conversation of, again, moving from a hospital base. Many of us have been born in hospitals. We do not live there, right? So if we wait for access to care in a hospital, we are too late. So how do we move the conversation, again, back to where people are and not where people end up? And then lastly, what I'll offer is that we must ensure that we are targeting and providing the person-centered, people-centered, population-centered impacts and interventions that we've discussed and continue to discuss. And then lastly, we have the clear metrics that actually tell the accurate story. Next slide. So this slide I always use, it's not so much for the details and the words on the screen, but it is a conversation of that downstream, midstream, and upstream, right? So as my daughter says, imagine a world, right? So imagine a world where everyone's living at the bottom of this stream. And, you know, people are jumping in the water and they're saving people, pulling people from the water. Some people they've been able to save, others have lost their lives in this water. We are throwing resources. We are sending as many people as we can to save as many as we can. And finally, someone looks upstream and they say, hey, what's going on up there? And upstream, they're like, okay, we've got to figure out what we can do here. Swim lessons. We'll make sure people have swim lessons so that they're stronger swimmers. They have a better chance of surviving at the bottom. We'll give them more food, make sure they have access to food and water, hydration, so that they can be stronger physically to make it work, right? Those are our social services, our kind of support systems, right? And then there are these people who are way at the top and they're asking the question, why are the people in the water in the first place? Right? The upstream thinking is actually asking, how did we get to this point at the bottom and what do we need to do at the top? Perhaps we should ask people, do you know how to swim? before they get in the water. Perhaps we should have some protection, some guardrails, so that people don't end up in the water. Because if we spend all our resources downstream, what we're doing is ignoring what's happening upstream, and then it depletes the ability for us to utilize resources further upstream. I offer that that's what we're doing a lot within the United States, and I would surmise that that's happening also around the globe. So travel with me upstream, and let's stay there in our conversation so that we can have an impact on those who are downstream. And if what it will do, it will open up our doors and our opportunities for what I have on the next slide. And I call this the concept of public health 4.0. We can switch to the next slide. So I talked to you about public health 1.0, 2.0, 3.0, and what I offer is that public health 4.0 is where we stand now as we've been informed by this COVID pandemic and understanding and peeling back the layers of what we in the public health community have known all along. We're not where we need to be. We need to take into context not only social determinants, but in our country, we absolutely need to understand the racial inequities that remain in the way of us achieving universal healthcare access and universal health, which is a right for all. And so I invite you to take a journey and understand what Public Health 4.0 looks like for you. I have charged nurses, the nursing community globally, to be a part of this. None of this is new for us. What we ask is that you invite us to the table for these important conversations, because what I've told the nurses across the nation and share with my colleagues across the globe is that when we don't get invited, we will actually bring a chair. And if there's no room for our chair, what we'll do is we'll create a table and we'll invite all of you to our party. But ultimately, the goal is that we all work together and we understand the different perspectives, because it is only through our work together that we can actually achieve our mutually agreed upon goals. Next slide. And so with that, I do say thank you. I appreciate the time. This was my fast and furious introduction to public health and especially public health nursing. Thank you.